today's session. Today's session's on cardiac MRI, CT. It's a case review, and I have the great pleasure of introducing Dr. Francois as our faculty for this case-based review. Dr. Francois is a professor of cardiothoracic imaging at Mayo Clinic, Rochester, Minnesota. He's a native of Minnesota and trained in Chicago at Northwestern and Loyola. His primary interests include 4D flow MRI, congenital heart disease, pulmonary hypertension, and advanced aortic imaging. We're very thankful that Dr. Francois has volunteered his time today to share his knowledge and expertise with us by bringing some awesome cases for us to learn from. And now we'll turn to Jordan, who will explain some of the logistics.
Hi, everyone. My name is Jordan McNamara. I'm a first-year medical student at the University of Arizona, and I'm going to be helping moderate a session with Cirrus. So this is going to be a traditional hot seat style review. Dr. Francois is going to be showing cases, and we'll be calling upon residents to take the cases. Each resident will take 2 cases at a time, and we have a list of case takers who have signed up to take cases, and we'll be posting the order in the chat so everyone knows when their turn is due. If anyone would like to take cases, please text us in the chat. We'll be monitoring the chat, and in order to minimize interruptions, we're going to take the questions at the end. So I will turn it over to Dr. Francois at this time.
All right, thank you very much for that introduction and for inviting me to share some cases. I'm going to be focusing primarily on cardiac MR and cardiac CT cases. If I looked at this yesterday just to see if there'd been any changes since last year. If you are not familiar with this already, I would encourage you to take a look at it, when you are studying it, is to review the ABR core exam on the ABR website. And because they go over all the critical concepts that they feel every general radiologist should know by the time they finish training. And within cardiovascular imaging, we expect you to be able to identify the imaging findings of myocardial ischemia and infarction, which includes knowledge of the coronary artery territories. Be aware of an approach to assessing atherosclerosis on CT, and then identify complications of myocardial infarction. In addition, we expect you to be able to diagnose some of the more common infiltrative cardiomyopathies, anomalous coronary artery disease, valvular stenosis and regurgitation, and then finally be able to recognize the diagnosis and management of acute aortic syndromes. Now, the other area where cardiovascular imaging will come up is in pediatrics. And if you look at the pediatrics critical concepts, they include the diagnosis of congenital heart disease, as well as the identification of some of the more common vascular conditions that we see in pediatric patients, specifically Takayasu's arteritis and Kawasaki's disease. And for the next hour and a half, I'm going to focus on these specific topics. Hopefully, there will be other faculty that will go over the acute aortic syndromes as well as vasculopathies in the pediatric population. And then, within each of these sections, they kind of break it down in terms of what percentage of the overall cardiovascular section is going to cover, these various topics. And so I try to include a mixture of cases from these areas, again, focusing on the heart. And so we're going to start with the coronary arteries. And I think, and we're going to start with, again, some hot seat cases, maybe for like the first hour or so. And then for the last 30 minutes or so, I was going to try to go through as many cases as possible, and then hopefully have some time to answer some specific questions. And so our first test taker I see is Ahmed. And so Ahmed, you are up. And the cases on your tests, they frequently will include some basic demographic information. And so I'll give you a moment or two to take a look at that here. So basically, it's a 53-year-old female who has substernal chest pain, dyspnea, lightheadedness. Troponin is normal. She has a history of hyperlipidemia and a sister with early coronary artery disease. And so the first question that I have for you is a technical question. Looking at this ECG plot from the CT scanner, do you think this is a prospectively acquired CT, or was this retrospectively gated?
Ahmed, are you there? If not, we can move on to the next case taker, George.
Yeah, thanks. Yeah, I can take it. So George, this looks like it's prospective gating. I see those bars like in every alternate cardiac cycle, I think.
Yeah, exactly. So here we have the ECG tracing. You have your R waves, or your QRS complex, your T waves, and what these bars indicate when the X-ray tube is on. Typically, when the heart rate is relatively low. In this case, it's varying from 53 up to 59. We turn on our X-ray source during diastole, and we acquire images during diastole during the quiescent period of the cardiac cycle, and then the X-ray source turns off. During the next R to R interval, the scanner is going to move to the next position. Now, if you're lucky to have one of these really wide detector CT scanners, 320 slice CT scanner that can cover 16 centimeters in a single rotation, you can scan the whole heart in a single rotation. But most sites will require a couple rotations to cover the whole heart. And so that's what this would look like. Okay. And we're going to go through these pretty fast. These first set, they're more technically oriented questions. There's a specific question that will, wait, no. So here we go. This is more of a cartoon explanation. We have the CT scanners detecting the peak in the R wave, goes out to diastole, turns on the X-ray, turns off, and then you move to the next position. And you can acquire over multiple heartbeats, or again, it could be a single heartbeat. We can widen that window if we want to acquire images during systole as well, or we can acquire data over multiple heartbeats or throughout the cardiac cycle if we want to assess cardiac motion as well. And then one of the things that we typically do, or we frequently do, to decrease the radiation exposure is we modulate the radiation dose. We lower the radiation during systole, and then we ramp up to 100% during diastole. Again, trying to get the highest quality images during the quiescent phase of the cardiac cycle, just to optimize our image quality. Okay, so this is still for George. This is still on our first case. The second question is, what type of visualizations am I showing in A and B?
So A is 3D volume rendered.
Yeah.
That's images, and yep. B like curved planar.
Exactly. So on the left we have this volume or surface shaded rendering. It looks fairly realistic. You have some three-dimensionality to it, and then on the right. This is the left anterior descending coronary artery that we stretched out along its length, and this is what we would call a curved planar reformatted image. And then finally, is there coronary artery disease?
No.
No, there is no coronary artery disease in any of these vessels. And nowadays, we are using the CAD-RADS reporting data system. Within the last year, they released a version 2.0 that includes some modifications to this. But again, that's come out in maybe the last 6 months. And so I don't know that they would expect you to know that data for this year, but probably for the following year, I would expect to start seeing some of the updated classification. And basically, the way CAD-RADS works is we sort of first distinguish between stable chest pain and acute chest pain. The CAD-RADS scores are the same, whether it's stable chest pain or acute chest pain. It's really based on the severity of the stenosis. But then the reason why it's important to distinguish between stable chest pain and acute chest pain is that the interpretation of the findings and then the recommendations for what the doctor should do next are different for the acute chest pain and the stable chest pain patients. Okay, so the next case, is Ahmed on, or should we move to Tyler?
Looks like he's not on, and I know Tyler's not available to take cases. We can move on to Mohammed.
Mohammed?
Yep. Are you available? Okay, or we can move on to the next one, which was YSMM.
Oh, I see. Okay, I see. Mohammed put a message in the chat box saying that his mic isn't working. Okay, that's fine. We'll just, you can put your answer in the chat box. Is that okay? So the first step is we're going to look at these images and tell me what you think. Tell me what you see. Yeah, and that's right. There is stenosis in this coronary artery. There is some high attenuation calcified plaque here in the proximal vessel. And then just a little bit beyond that calcified plaque, there's a very low attenuation plaque. First question for you, Mohammed, which coronary artery do you think this is? Is it the left anterior descending? Is it the circumflex? Or is it the right coronary artery? RCA. So it can be very difficult on these oblique views to figure out exactly, which vessel we are looking at. And so you kind of have to look at the surrounding structures. And so this is the ascending aorta. This is the pulmonary artery. Down here, this is the left ventricle. And the coronary artery that goes that kind of goes underneath the main pulmonary artery, and then the left atrium, left ventricle, is going to be the left main and then the left anterior descending. The left anterior descending is going to go over the anterior wall of the left ventricle, whereas the circumflex is going to go down the left atrioventricular groove, and then the right coronary artery is going to go down the right atrioventricular groove between the right atrium and the right ventricle. So this is the left anterior descending coronary artery. And then final question for you, Mohammed, which of these plaques is more likely to rupture? The proximal calcified plaque or the more distal low attenuation plaque? Which one are we worried about? Which one of these is a high risk plaque? Exactly. This distal non-calcified plaque, that's the one that we worry about. The low attenuation, positive remodeling, napkin ring signs, those are all features that we associate with high-risk plaque. Okay, so next case, who do we have next? Is it YSMM? YSMM?
Or we can move to Stephen.
Hi, yeah, I'm here.
Okay, so this next case, again, chest pain. This is the left anterior descending coronary artery. Tell me what you see.
All right. Within the proximal aspect of the LED, there's a mixed calcified, non-calcified plaque resulting in severe stenosis. And then there's, I guess, maybe a short segment of myocardial bridging distally.
Yeah, exactly. So here proximally, there's a severe stenosis. The plaque is predominantly low attenuation, fat attenuation, so it's a lipid-rich plaque. When you look at the cross-sectional view, you get a sense that there is some positive remodeling. There's some calcified plaque in it as well. And then more distally, there's a short segment of myocardial bridging. Okay, who's next? Looks like some people signed up, so maybe Derek?
Yep.
Sure.
We have another chest pain patient.
Okay.
This is also the left anterior descending.
Looks similar to the last case. Severe stenosis, non-calcified plaque, distal to one of the, I can't remember if it's marginal, diagonal branches coming off that side of the LAD.
Yeah, exactly. So this is the left anterior descending coronary artery. You can see there's very, very severe stenosis. It's lipid rich, very low attenuation, very, very concerning. The branches off of the LAD are diagonals. So LAD has a D in it, and so the branches also have a D, diagonal. The RCA has the acute marginals, and then the LCX, because it has an X in it that has obtuse angles, has the obtuse marginals. So LCX or circumflex has obtuse marginal branches, LAD has diagonals, and then the RCA has acute marginals. How do we assess cardiac remodeling on CT? Let's go up to this case. So the positive, we call positive remodeling when the plaque sort of extends out from where we would expect the normal adventitia to be. So let me get my pen out, my white pen. So if this is our vessel wall, and then we have some plaque in here, that's sort of kind of what we're seeing in that next case. When we have positive remodeling, the plaque extends out beyond the vessel wall. It almost looks like a ring where you have the lumen down here, and then the plaque and inflammation and hemorrhage out here. And when the vessel wall is expanding outward, that's the positive remodeling. Does that make sense? Okay, next case.
We've got Hawaii next.
Okay.
Hi. Just
We have another. Yes. Let me get rid of my pen. Okay, chest pain. Still the
Okay.
LAD here. What do you see?
I see a multifocal area of calcification or calcified plaques.
Yeah, and do you think it's causing mild, moderate, or severe stenosis?
So at some point, there is like a short segment of severe stenosis in the proximal LAD after the bifurcation. And I see a non-calcified plaque over there where it's causing severe stenosis, and the rest is like calcified plaque with mild to moderate stenosis.
Yeah, exactly. So this is multifocal coronary artery disease with an area of severe stenosis in the proximal LAD. And it's very low attenuation again. That's the kind of plaque that we're worried about. Okay, next case, another chest pain case. Who's up for this one?
All right, we got Kenneth Brock.
Okay,
Hey, how you doing?
good.
Okay, let's see here. So we're looking at a cardiac CTA or coronary CTA. We're centered at the ascending aorta, and I think what I'm seeing here is an anomalous origin of the right coronary artery, which looks like it's between the pulmonary trunk and the ascending aorta. So I think this is a malignant RCA origin.
Mm-hmm. Yeah, so the right coronary artery has an anomalous origin from the origin of the left main coronary artery, and then it has it courses between the main pulmonary artery and the aorta, which is often referred to as a malignant course. Now, the way we describe anomalous coronary arteries has changed a little bit over the last 5 to 10 years or so. It used to be thought that what was important was whether or not the coronary artery went between the aorta and the pulmonary artery, and that was it. It turns out it's a little bit more nuanced than that. And what really matters is not so much whether or not that anomalous coronary artery is going between the aorta and the pulmonary artery, but whether or not that anomalous coronary artery is coursing through the wall of the aorta. And that's what we refer to as an intramural course. So within the wall of the aorta. And the clues to detecting an intramural course are kind of twofold, two main things that we're looking for. The first is, does that proximal anomalous coronary artery course in very close proximity to the aortic wall? So if you look at this vessel here on the top row, and then here in the middle row, it is coursing in very close proximity. It's hugging the wall of the aorta before it goes out into the periaortic fat. And then the second thing that we're looking for is on the sagittal oblique reformatted images. We are looking for flattening of that proximal anomalous coronary artery in the AP dimension. So if you look at the proximal right coronary artery, it's rather flattened in the front, in the AP oblique dimension. And that's what we now consider to be in a sort of a malignant anomalous coronary artery. And now it's become even more nuanced than that, because we detect these anomalous coronary arteries incidentally in 60 and 70-year-olds who never have had any chest pain. And so now more than ever, we kind of look at whether or not the patient have any symptoms and whether or not they have any signs of ischemia, particularly when we're dealing with anomalous right coronary arteries. For the anomalous left coronary arteries, we're still primarily worried about the anomalous left coronary arteries that have an intramural course, as opposed to those that sort of take a transeptal course. But in general, if you have an intramural anomalous left coronary artery, people will fix those, even if they don't have any history of chest pain. So going to kind of step through this montage. Here's the origin of the left coronary artery, and now it's starting to come out along the wall of the proximal aorta, and then it's diving out into the right atrioventricular groove. And then here is the proximal right coronary artery, ascending aorta, main pulmonary artery. The right atrium is a little bit lower in attenuation just because of the timing of our image acquisition relative to the contrast bolus. Okay? All right, here's the next case. Who's up next?
Eric is up next.
All right. Okay. So off the anterior cusp of the aorta, it almost looks like a common origin of the, or a very close origin of the LCA and RCA.
Mm-hmm.
Yeah, maybe then it's an anomalous position of the RCA. I guess that should come off the. I'm sorry, that. No, that's right. It's coming off the wrong cusp.
Yeah, so this is sort of a nice companion case to that previous one. Now, again, to kind of orient yourself anteriorly, we have the sternum. The most anterior ventricle is the right ventricle. The right atrium is the rightwardmost cardiac chamber, aorta, and then posteriorly we have the left atrium. And so the coronary artery that goes between the right atrium and the right ventricle is going to be which coronary artery, Eric?
That's the right. RCA.
Yeah, exactly. So this is the right coronary artery, right cusp, posterior cusp, left cusp. And so this is the anomalous left coronary artery coming off of the right cusp and then coursing in between the aorta and the main pulmonary artery. And we would want to look at it carefully in the sagittal oblique view to see if there's any signs of compression. But even if we don't see any severe compression of that left coronary artery, given the fact that it seems to be coursing very close to that aortic root, most people would consider this to be, an intramural course within the wall of the aorta, and would require unroofing. Okay, next case. Who's up next?
All right, we've got Osama Awan.
Okay. So another chest pain.
Yeah, so it looks like the left main is coming from the non-coronary cusp.
Yeah, exactly. So, there's some variation into how people describe the cusps of the aortic root. The right and the left cusps, everybody agrees on. But what should we call this cusp, that third cusp? A lot of people will frequently call it the non-coronary cusp. But to me, it sounds a little strange to say that you have a coronary artery coming off at the non-coronary cusp. And so I refer to it as the posterior cusp. And that is the preference here at the Mayo Clinic as well, outside of radiology, within cardiology and cardiac pathology. But you'll see to it, like on exams, you'll see people refer to it as the non-coronary cusp or the posterior cusp. Now, the question I have for you, Awana, is are you worried about this? Is this something that needs to be repaired? If the patient has chest pain, is this the cause of the patient's chest pain?
No, I don't think it's a worrisome anomaly.
Yeah, correct. So this is sort of an incidental finding. If the patient has chest pain, this is not the cause of their chest pain. Okay, who's up next?
We've got a question from someone who asked, how can you decide if the artery is intramural or not?
Oh, yeah. So let me go back one and get out my pen. And so if this is your aortic root, if you have the right coronary artery comes out and it has a very acute angle and it's following the course of the aortic root very closely, that's a good sign that it is within the wall of the aorta. And that would be in distinction to this scenario where it kind of goes out with a more obtuse angle and it gets out into the periaortic fat before moving over to the right atrioventricular groove. So that's the first sign. And then the other way is to look at it in the sagittal oblique view, where you've got your aorta going up like that. If you see that the anomalous coronary artery is flattened like that, that would indicate that it is intramural within the wall of the aorta, as opposed to a vessel that is not intramural. It's out in the periaortic fat. It is not going to be compressed. It's going to have a more round contour. Does that make sense to everyone?
Makes sense.
Okay.
Thanks. Up next, George. Back to George.
Okay, George.
Thank you.
Mm-hmm.
Back to 3D volume rendered images.
Mm-hmm. Yep.
So we're looking at the coronary arteries, I'm guessing.
Yep.
Trying to figure out. I see this vessel that appears to be like going anterior to the pulmonary arteries. Pulmonary artery.
Mm-hmm. Yeah, this one right here.
Can't figure out. So that's wait, that's a right side. So if that's the AV group, then that's the RCA, right?
Correct.
And
so that's an anomalous course, well, anomalous origin of the right coronary artery, and then an anomalous course. And as you correctly pointed out, we have the pulmonary artery right here. Here is the aorta. And so what do you think of that course of the right coronary artery?
Is this that the pre-pulmonic anomalous course?
Yeah, exactly. Pre-pulmonic, because it is in front of the pulmonary artery. And are you worried about this? Is this going to cause chest pain?
I would. Not sure. This is pretty superficial. Like, I don't know. I'd be worried if somebody tries to operate, but otherwise, I'm not sure, really.
Yeah, exactly. So, this is not going to cause angina. This is not an intramural or malignant course. This is an incidental finding. And then, as you mentioned, it would be important if they were going to undergo cardiac surgery or have a sternotomy. It would be important for the surgeon to know that they've got a coronary artery right behind the sternum. And to answer Rasha's question, the intramural course is kind of what we would now consider to be the malignant course. And that would be an indication for surgery, particularly if they have chest pain. So the normal course, so normally the right coronary artery is going to go we won't see it on this view. You won't, because it doesn't come off of the left coronary artery. It comes off of the right cusp, which is going to be hidden behind the pulmonary artery, and then you'll see it come out here in the right atrioventricular groove. Okay, next case.
All right, Stephen.
Hello. Okay.
Hey, Stephen.
So this is a view of the LAD. There's calcifications, calcified atherosclerosis of the proximal LAD, resulting in mild stenosis.
Yeah, so on the left, we have the left anterior descending coronary artery. There's some calcification. There's some non-calcified plaque. Which vessel do you think this is over on the right?
Yeah, so the RCA.
Yeah.
And that also has calcifications proximally. I'm wondering if there's kind of like little aneurysms, like distally.
Yeah, there is some ectasia. Like, so the proximal right coronary artery, this was about 8 millimeters, and similarly for the proximal left coronary artery, that measured up to 9 millimeters. So we have some calcifications, some non-calcified stuff, aneurysms. What do you think the cause of the coronary artery aneurysms is in this case?
Could it be like Kawasaki's?
Okay. What else? Now, what's the typical demographic of a patient with Kawasaki's disease?
They're usually children, younger.
Yeah, exactly. Now, this is a 65-year-old.
Okay. So maybe another type of vasculitis. So let's see.
So yeah, vasculitis, and then something that's a lot more common than vasculitis in Kawasaki's can also give aneurysms. Is atherosclerosis. So, so this is a patient that has atherosclerotic coronary artery aneurysms.
Okay.
And so the best way, and if this patient was 15 years old, this would be Kawasaki's disease. In a 65-year-old or 75-year-old, it's atherosclerotic disease. Okay. Vasculitides, there are some vasculitides that can give coronary artery aneurysms as well. IgG4 related disease can also give coronary artery aneurysms. That was one of the cases of the day at RSNA last year. But that's something that's rather obscure and wouldn't show up on a board exam with regards to coronary artery aneurysms. IgG4 related disease would certainly show up in other sections of the exam, but not necessarily in the context of coronary artery disease. And then, Rasha, you asked how do we grade stenosis as mild, moderate, and severe? Is it subjective? No. If you like before, when I showed the table for the CAD-RADS scoring system, it kind of breaks it down in quartiles, and so from if the stenosis is 1% to 24%, we would call it minimal. If it's 25 to 49%, we would call it mild. 50 to 69 is moderate. 70 to 99 is severe. In practice, when on a busy clinical day like today, when I had like 30 cases. I predominantly just do it visually, decide, is it, subjectively, does it look like it's less than 25%? Is it between 25 and 50, between 50 and 70, or is it more than 70? If it's on the border, I will look at the curved planar reformats, and I will make some measurements. There are also stenosis tools within most visualization software packages that can give you a more precise diameter or area score or severity for stenosis. But most of the time you can just grade it pretty easily, very quickly, just by looking at it. Okay, next case.
All right, we've got Ufara Suwasti.
Okay.
So this is RCA.
Correct.
We have multifocal segment of dilatation, especially in the proximal one, and probably I don't know if that's like a thin line of calcification, but it's not as extensive as, probably like the degree of dilatation is more than the calcification.
Yeah, exactly. So what do you think this patient has?
So I think in this case, if the previous one is like more on the atherosclerotic disease, this one is like vasculitis.
Yes, exactly. So this is, back when we had oral exams, the way you would have said the diagnosis would have been to say, if this patient is 15 years old,
okay.
This is Kawasaki's disease. However, if this patient is in their 40s, maybe it's a vasculitis like Behçet's, Takayasu's disease, IgG4 related disease, something like that. Okay. But if they're in their 70s, it's atherosclerosis.
Right.
Okay, now we're going to change topics a little bit. I have some congenital heart disease cases now. So who's up next?
We've got Hawaii.
Okay.
Hello.
Hi.
Okay. So we have two 3D volume rendered images of the heart. Okay, and we need to know what type of surgery has been done for this patient.
Correct.
Okay. So.
And so let me put an arrow here. Make sure I have the correct color. Let's do white. So that's the surgically created shunt right there.
Okay. So we created a communication between the is it okay?
And then guy just
that's the aorta.
Yeah. And then here's the descending aorta over here. We're looking at it from the back now.
Okay. So we're trying to create a shunt for a congenital heart disease that requires a shunt.
Yeah.
Otherwise, they won't survive. That's what I'm thinking about.
Yeah.
So, okay, so that would be a transposition of the grade. No, 1 second. I see the aorta arising from the right ventricle.
Mm-hmm.
And the pulmonary artery is arising probably from the left. So transposition of the great arteries.
Yeah, so there actually isn't a main pulmonary artery in this case, and so that's why they've done a shunt between the aorta and this is going to be the left pulmonary artery right here. This is the left pulmonary artery over here. And so I'll give you a couple options. One is a Glenn.
Okay.
One is a BTT shunt, Blaylock-Taussig Thomas. Used to be called just Blaylock-Taussig, but we now call it the Blaylock-Taussig Thomas shunt in recognition of Dr. Thomas, who was very instrumental in making this shunt happen. And we have a Fontan. Is another option. Or how about a Jatine?
Okay, so I know that Fontan procedure is, in Fontan procedure, the systemic venous return will be connected into the pulmonary arteries by bypassing the heart.
Yep.
So that will be seen in patients with single ventricle. So I'm not gonna pick Fontan.
Okay.
The other options are I can't remember what was Glenn. I'm not sure.
Okay. So this is a Blaylock-Taussig Thomas shunt where we connect most often the left subclavian artery to the left pulmonary artery. In this case, the patient has a right-sided aortic arch, and so the first vessel off the arch is the left brachiocephalic, and so they created a shunt connecting the left brachiocephalic to the left pulmonary artery. And that's the first step sort of in the Norwood procedure, sort of the first step toward what ultimately will become a Fontan or a total cavopulmonary palliation. And I'm not going to go over the other ones just quite yet because we'll see those subsequently. Okay.
Thank you.
So who's up next?
Got Kenneth Brock.
Okay.
Hello. Boy.
So on the right, this is
best
a
here.
movie showing blood flow that we did with a 40 flow MRI sequence. Blue blood is venous. Red blood is oxygenated blood. And so what I'm primarily interested in knowing is what do we call that shunt?
Okay, so this is assuming having been repaired, not a congenital shunt.
Correct. Yeah. So what do we call that repair? That surgical shunt.
This looks like, okay, so it's venous blood, and looks like it's going towards the right atrium, and it's connected to, the aorta's there. I don't know if I see the pulmonary trunk. It looks like it's connected to pulmonary veins, if I had to guess.
So which vessel do you think? So this is which vessel is this right here?
That looks like the right innominate.
Yes, exactly. And then over here, which vessel is that?
Left innominate, or
okay.
Yeah.
And then when they come together.
Okay, so you should have your SVC there.
Okay. And normally the superior vena cava doesn't go out to the pulmonary arteries, right? So that's what they've done in this case. They've connected the superior vena cava to the pulmonary artery. So our deoxygenated blood is coming down the SVC and then going out to the pulmonary arteries. And so do you remember which one of these four is that shunt going to be? Is it the Fontan? Is it the BTT? Is it the Glenn? Is it the Jatine?
I think that would be Fontan, since it's bypassing the heart.
Close. This is one step before we do the Fontan. And
gotcha.
This is the Glenn.
So the Glenn, yeah.
Yeah. And so, the first stage would have been the BTT shunt that we saw previously, where you connect basically the systemic artery to the pulmonary artery, usually the subclavian artery to a pulmonary artery. They used to bring it down directly, but now they use a graft, a synthetic graft, to connect the subclavian artery to the pulmonary artery. It can be on the left, it could be on the right. And then when the patients are a little bit older, they do the next phase, the next stage, where they start to bypass systemic venous return toward the pulmonary arteries directly. And the first step is to divert superior vena cava blood to the pulmonary arteries. And so they bisect the pulmonary artery, if there is one. If they don't have a pulmonary artery, then they just connect it up directly to the right and left pulmonary arteries. And this is called a Glenn. Okay?
We have a question.
Thank you.
Somebody asked if you could go over the indications for these procedures.
So briefly, in the interest of time, so the BTT shunt, the Glenn, the Fontan are done for patients that have either single ventricle physiology primarily. And so when you have one ventricle or one good ventricle, then that ventricle has to be the pumping out to the aorta. And so we need to come up with a way to surgically divert blood from the systemic veins to the pulmonary arteries. And that's it's usually a 3-stage process, starting with the BTT, then the Glenn, and then the Fontan, which we see here, where they connect the inferior vena cava directly to the pulmonary arteries. And so now we have this total caval pulmonary connection where the superior vena cava or the Glenn connects to the pulmonary artery, the IVC or the Fontan connects to the pulmonary arteries. And so common lesions that this is used for would be tricuspid valve atresia. You could also use this in patients who have hypoplastic left heart syndromes due to mitral valve atresia or aortic valve atresia. Those would probably be the most common lesions that these are used for. But basically, if you have any congenital heart defect where you only have one good functioning ventricle, this is going to be the way to palliate that. And with regards to Fontans, there's a couple different flavors of connecting the inferior vena cava up to the pulmonary artery. The older way was what they called an intracardiac Fontan, where they would just use the entire right atrium and take the IVC, it goes into the right atrium, and then they would sew the right atrium up to the pulmonary artery. Now, that doesn't work very well in the long run because the right atrium starts to dilate, and then as it dilates, the blood flow starts to slow down, and then as the blood flow slows down, it starts to thrombose. And you get what you see here, large thrombi within the right atrium. It's a very inefficient way of moving blood passively from the veins to the pulmonary arteries. Then we have the extracardiac Fontan. This is what's done most often here in the United States, where we use synthetic material, usually a Dacron graft, to connect the suprahepatic inferior vena cava up to the pulmonary arteries. And it goes outside of the right atrium. Now it doesn't grow over time. What can happen is it can start to collapse, or you can develop thrombus inside. Most usually the material of these grafts is a Gore-Tex. Some people have used Dacron, but Dacron is thrombogenic, and so now they've moved to Gore-Tex grafts. So these are usually Gore-Tex grafts. They can become stenotic over time, especially at the anastomoses. And so when we're following these patients, that's kind of what we're looking for is thrombosis. All right. So last question related to surgical repairs. This can be for the next hot seat taker. This is not done for hypoplastic ventricle or single ventricle repair. This is a different kind of repair. And we're looking from the top down.
Okay. What is going on here? So the palm, is there some kind of anomalous branching of the right or the pulmonary arteries that's been corrected?
Yeah, so describe to me what you are seeing.
Sure. So, normally I see the main pulmonary artery go to the left of the aortic arch and then bifurcate, but it seems like that's been changed, or?
Yeah, so here we're looking top down, and the patient is sort of the way I'm displaying this, the patient is in a prone position. So here's the main pulmonary artery, the right pulmonary artery, the left pulmonary artery. In this case, the main pulmonary artery is bifurcating in front of the ascending aorta. And so this is done for patients who have a history of detransposition of the great arteries. And this is part of the arterial switch operation. And so this would be part of like a Jettine maneuver with the LeConte. So it's a Jettine with a LeConte maneuver. So this specific configuration where they place the pulmonary arteries over the front of the ascending aorta, that's called the LeConte maneuver. So this is part of an arterial switch operation for patients with detransposition of the great vessels or arteries. And so the question on the test might be, what was this patient's congenital heart defect? Was it tetralogy of Fallot? Was it mitral valve atresia? Was it L transposition or was it D transposition? And the correct answer on that multiple choice question would be D transposition of the great arteries. Okay. So this is a 45-year-old with high blood pressure, and they got a chest X-ray.
Osama next, and we're at the 1 hour mark about.
Yeah, we'll go through the congenital heart disease cases and then maybe a couple more of the non-congenital things.
So frontal radiograph, I see looks like maybe a broad-based opacity superior to the aorta on the left side, to the left paratracheal area. Not sure what that would be. Maybe pleural-based. Hard to tell.
Yeah, so if we thought, this is the abnormal opacity. It looks like it's posterior mediastinal. And so, within the posterior mediastinum, we have sort of neurogenic things. So maybe this is a neurogenic tumor. Maybe it's kind of extra pleural or pleural. So maybe like a pleural fibrous tumor. But we also have vascular structures back there, and this is a cardiovascular case conference, and so it's most likely going to be that. But to kind of figure out what this is more definitively, what would you recommend?
Oh, cross-sectional imaging for sure, but
Yeah, CT or MR, and along the cardiovascular differential, what would you consider, Usama?
yeah, aberrant right subclavian.
Okay, sure, that's a possibility. With a diverticulum of Commerl, it's aneurysmal. So we got a CT, and here's the volume rendered image for you.
Oh, looks like coarctation.
Yeah, so this is a coarctation. This is a very severe coarctation. Okay, next case.
All right, back to George.
All right, thank you. See some cine images. I'm wondering if these are, like bicuspid aortic valves.
Yeah, so this is, it's all the same patient, kind of a large field of view here on the left, and then zoomed in views kind of going very thin slices through the aortic valve. This is a bicuspid aortic valve. Is this associated? What is this commonly associated with?
I know this is associated with Turner's.
Okay. What else?
Look at the others. Associated with aortic stenosis.
Yeah.
Sometimes coarctation of aorta.
Yeah, coarctation is the other big one that it's associated with. Okay, next case, 13-year-old with a systolic murmur. And whoever's up next, what is the artifact that you are seeing here in this image?
Stephen?
Yeah. Is this like aliasing artifact?
Yeah, exactly. So this is aliasing artifact. And so do you remember what's the parameter that we would need to change to get rid of that aliasing artifact?
You'd want to increase, I guess, the velocity, like some sort of. I think if I saw it on a question, I'd probably recognize it. But you just want to increase some like threshold that it senses.
Yeah, exactly. And so we call that the velocity encoding, or VENC. And so the multiple choice question might be, which parameter should you adjust? Is it the VENC or the velocity encoding? And that would be the correct answer. Other options that they might put on there would be, flip angle, repetition time, time to echo, bandwidth, and all of those would be the wrong answer. So when you see aliasing on a phase, contrast, flow sensitive MR image, it's because your velocity encoding was set too low. And it works in the same way as aliasing on Doppler ultrasound. And so we increase the velocity encoding, and that aliasing goes away. And if you'll look at the difference between these two images, the other thing that I would like to point out is that white and black do not necessarily mean forward or backward. It really depends on how you set up your acquisition. So if I just rotate my field of view for this acquisition, what is black would become white, or vice versa. So you can't really rely on the color of the signal to decide whether or not it's forward or backward flow. You kind of have to look at other things in your image. So for example, here in the descending aorta has sort of white flow. Descending aorta is going down towards the feet. Here in the aorta, the flow should be going towards the head. So it's in the opposite direction of the descending aorta. So it should be black. The other thing to look at is when you have aliasing, the aliasing looks very noisy. It has these very rigid steps to it. So that's the other clue that this is aliasing as opposed to normal white colored flow. Okay. Next case is a preoperative chest X-ray, this is, I'll go through this case. What we have here is a right-sided aortic arch, sort of a widened mediastinum, a big cardiac silhouette with elevation of the right ventricular apex. Kind of looks like a boot. It looks like some of the snow boots that many of us up in the northern part of the United States are wearing right now. So we have a boot-shaped heart with a right-sided aortic arch. What do you guys think the diagnosis is?
Where the next?
Yeah, you helped me a lot. It's tetralogy of Fallot.
Yeah, exactly. So this is tetralogy of Fallot. And so what are the four things, Awada, that make up the tetralogy of Fallot
So
that you see on this patient's cardiac MR?
So on the first row, I see a ventricular septal defect.
Yes.
And then like I see overriding of the aorta and
yes.
Mm-hmm. And I see it mainly in the third row, if I'm not mistaken. And I'm searching for a pulmonary stenosis, but I didn't find it yet.
Yeah, so this is the most severe form of pulmonary stenosis. So if you come here to the right pulmonary artery behind the ascending aorta, it just sort of ends in a stump. It does not connect to the right ventricle. So that would be pulmonary atresia. So you have VSD, overriding aorta, pulmonary atresia or stenosis, and then the fourth thing, which is related to the pulmonary stenosis.
Yeah, ventricular hypertrophy.
Yes, so we have right ventricular hypertrophy. Exactly. Next case, this is another classic board exam kind of case. Beautiful.
I can take it because I cheated on the first one.
Okay.
I'm happy to take it. So it's a scimitar sign on the chest radiograph. So that would be partial anomalous pulmonary venous return. Yes. And also we see the size of the lung. It's a little bit smaller on the right from the left side. Yeah, so this is scimitar syndrome, partial anomalous pulmonary venous return. All of the right lung is going back into to the inferior vena cava. And then this is another example of partial anomalous pulmonary venous return. In this case, it's the right upper and middle lobes that are draining into the superior vena cava. There is also a septal defect, an atrial septal defect. And this specific type of septal defect is a sinus venosus atrial septal defect. So this is a patient with partial anomalous pulmonary venous return with a sinus venosus atrial septal defect. And I think in the interest of time, I'm going to go through these cases rapidly now so we see some other types of pathology. This is a chest X-ray showing massive pulmonary arteries. The right pulmonary artery and the left pulmonary artery are much larger than the aortic arch. The central pulmonary vessels are also dilated. This is a patient who has pulmonary hypertension. On the lateral radiograph, you can see that the right ventricle is enlarged, occupying the retrosternal clear space. The patient had a CT scan showing massive pulmonary artery enlargement, almost double the size of the ascending aorta. And then if we come down a little bit lower, you can see there's a very large segundum atrial septal defect, sort of a standard multiplanar reformatted view, and then a surface shaded view here on the right that kind of shows that atrial septal defect nicely. Here's another atrial septal defect. In this case, this is a primum atrial septal defect. The atrial septal defect is right up against the mitral valve and tricuspid valve. So primum atrial septal defect. This is a 34-year-old. We have a cardiac MRI right now. This is a 4-chamber view. The right atrium is humongous.
So a primum defect is going to be right next to the mitral valve and tricuspid valve, so a little bit more anteriorly located. The secundum defect is sort of in the middle of the atrial septum, so it's going to be a little bit further back than a primum ASD. So we have, in this case, we have a very large right atrium, very large right ventricle. The septal leaflet of the tricuspid valve is attached too close to the right ventricular apex. So this is Epstein's anomaly. Epstein's anomaly, the tricuspid valve is displaced more than 15 millimeters towards the apex relative to the mitral valve. This is a very severe form of this. We have atrialization of the right ventricle. This is a 31-year-old. We see persistent connection between the main pulmonary artery and the descending aorta. This is a patent ductus arteriosus. And here is a 4D flow image to kind of illustrate this persistent connection. Here's the right ventricle, main pulmonary artery coming up, and you can see a lot of the main pulmonary artery blood flow goes directly over to the descending thoracic aorta. Here's the left ventricle going up into the ascending aorta. And so we have some more cases moving beyond coronary arteries and congenital heart disease. This is a patient presented with an ST elevation MI, and this chest X-ray shows isolated right upper lobe consolidation, and in a patient with who just came in with a STEMI, if you see isolated right upper lobe consolidation, this is lung edema, you want to think about a ruptured mitral valve. So when you have acute rupture of the mitral valve from a very large myocardial infarction, you get florid mitral regurgitation, and that mitral regurgitation jet is going to be directed from the left ventricle, which is over here, into the left atrium and right up into that right superior pulmonary vein. So the right superior pulmonary vein pressures are going to be a lot higher than all of the other pulmonary vein pressures, giving you this sort of asymmetric right upper lobe lung edema. This is a CT scan from a couple months ago. Patient presented with chest pain. This was supposed to be a PE study, but the contrast kind of got diluted, so it wasn't a really good PE study, but it does illustrate very nicely this hypoattenuation along the subendocardial surface of the anterior wall and the anterior septum of the left ventricle. And so this was on the CT scan, we were able to identify the ST elevation myocardial infarction. So when you're looking at the heart in patients who present with acute chest pain, even if it's just a PE study, make sure you widen the window and level enough so that you can look at the enhancement of the myocardium. You will pick up once in a while signs of a myocardial infarction. You'll see this resting perfusion defect. This is a 35-year-old who presented with chest pain, very similar to that previous patient. This is a cardiac MRI. The cine images show global severe hypokinesis and akinesis of the anterior septum and apex. On the late gadolinium enhancement images, we have transmural enhancement in that anterior septum and true apex. That enhancement is transmural. This is a transmural infarct. This dark area that you see surrounded by the white enhancement, that is microvascular obstruction. That indicates that this is a very, very severe myocardial infarction. This patient has a very, very poor prognosis for recovery, even if they go in and open up his occluded LAD. On the cine images, you can also see there's a small jet here from the mitral valve that is mitral regurgitation. This is a 78-year-old that we did a cardiac MRI in after they presented with a cardioembolic stroke. We did the cardiac MRI to look for intracardiac thrombus because they had some contraindications to transesophageal echocardiography. We have a bright blood image on the left, a delayed enhancement or late gadolinium enhancement image in the middle, and then a pre-contrast T1 weighted image on the right. And the image in the middle shows a transmural infarct involving the entire anterior wall, the left ventricle, and then this large blob inside that aneurysmal infarcted territory. It is inherently bright on the T1 pre-contrast images. This is a large thrombus. Thrombus in the heart, just like thrombus in the brain, can be bright on the T1 weighted images. It does not enhance after we give contrast. This is another patient who presented with acute chest pain. Additional relevant clinical information in this case. This is an 85-year-old woman, and 2 weeks ago her husband passed away, and so this is stress-induced cardiomyopathy, left ventricular apical ballooning, or Takotsubo. They're all synonyms of each other. And what you see here on the cine images, these long axis cine images, is akinesis of the apical left ventricle. The basal left ventricle still is contracting very nicely. And then on the late gadolinium enhancement images, in this case, we do not see any enhancement. Originally, it was thought that you never saw enhancement in stress-induced cardiomyopathy, but as we've imaged these patients more and more, they do occasionally have small areas of ischemia. And so, really the key to differentiating this from, coronary artery disease is to look at the coronary arteries. Because these patients frequently have some mild troponin elevations and non-specific ECG changes, most of them go to the cath lab and they show clean coronaries, and then we do the cardiac MRI to see if this is, in fact, stress-induced cardiomyopathy or some other non-ischemic cardiomyopathy. So this is again, fairly typical for the last couple of years, 43-year-old presenting with fatigue and dizziness after a recent COVID-19 infection. The bright blood images show a pretty hypokinetic left ventricle, a small pericardial effusion, and then on the right, we have late gadolinium enhancement images showing focal mid-myocardial enhancement here in the inferior septum. This is a non-ischemic pattern of enhancement that would be consistent with myocarditis. In the middle image, I am showing you a T2 map image, which we're starting to do more and more frequently, and this is elevated. The normal T2 values range from about 40 to 60. Anything above 60 is going to be elevated. And so this is clearly above 60 degrees. This is elevated. This is indicative of myocardial edema. So this is a patient who has myocarditis related to their recent COVID-19 infection. Now we have another 42-year-old, this time presenting with complete heart block. Cine images don't really show much of anything, but the late gadolinium enhancement images show diffuse abnormal enhancement. Here involving the right ventricle, the anterior wall of the left ventricle, the inferior wall of the left ventricle, lateral wall, everywhere. We've got this patchy enhancement, but it is not ischemic. It is not subendocardial. Rather, it is subepicardial. This, again, it could be myocarditis, but in a patient who's presenting with heart block, we're more inclined to call this sarcoidosis, or we're going to put sarcoidosis number 1. And the the appearance of sarcoidosis and myocarditis is frequently very similar on these late gadolinium enhancement images. Many times we can't tell the difference. And so what we recommend in our impression is that they get we look at the clinical history. Did they have a recent infection? Then it's most likely myocarditis. If they have not had any recent infections or infectious symptoms, but rather it's more of an insidious presentation where they have a heart block, then it's more likely to be sarcoidosis. We would recommend, if we think it's sarcoidosis, we would recommend a chest CT to look for any signs of thoracic sarcoidosis. This next case is a patient with heart failure. On the cine images, the left ventricle is hypertrophied. There is concentric left ventricular hypertrophy. These late gadolinium enhancement images, they do not look pretty. And that's really your first clue in making the diagnosis in patients with cardiac amyloidosis. The late gadolinium enhancement images in patients with amyloidosis never look very good. They're often very noisy. It's very difficult to null the myocardium. But when you do, what you do frequently see is this diffuse subendocardial enhancement involving both the left ventricle and the right ventricle. And then you'll also see enhancement of the wall of the atria, which you see in this case. So this is cardiac amyloidosis with diffuse subendocardial enhancement involving the left ventricle, the right ventricle, as well as atrial enhancement. Another case of heart block. This time we have a non-contrast CT followed by a contrast-enhanced CT, and we have a well-circumscribed fat attenuation mass within the interventricular septum. This is a lipoma. This is a 49-year-old who has some shortness of breath, some palpitations, and we have a very hypertrophied interventricular septum. It is obstructing the left ventricular outflow tract, and so you can see the flow dephasing due to the turbulent flow in the left ventricular outflow tract. This is also causing the anterior leaflet of the mitral valve to move anteriorly, so that's what we call systolic anterior motion of the mitral valve leaflet, giving some mitral regurgitation posteriorly here. So hypertrophic cardiomyopathy. In this case, we would call it hypertrophic obstructive cardiomyopathy with LVOT obstruction, systolic anterior motion of the mitral valve, and mitral regurgitation. In these patients, we always get late gadolinium enhancement images. About 60 to 65% of the patients will have some late gadolinium enhancement. Again, it's non-ischemic in distribution. It's mid-myocardial, most often in the areas that are most hypertrophied, like you see here in this case. T1 mapping is used more and more in these non-ischemic cardiomyopathies. I still think because it's not universally used clinically, it's probably still a little too early to show up on a board exam. But I do show it just so that you have seen it. In patients with hypertrophic cardiomyopathy, cardiac amyloidosis, myocarditis, the native T1 times and the extracellular volume goes up. In patients with Fabry's disease, the T1 times actually go down. Again, I just point this out for curiosity, for interest. It adds some color to the presentation, but I don't think that T1 mapping is going to show up on your board exam just quite yet. This is another patient with heart failure. There is concentric left ventricular hypertrophy. The native T1 time is markedly elevated at 1,100. The normal native T1 values at 1.5 Tesla are between 900 and 1,000. Anything above 1,100 is definitely very elevated. And so this was a patient with, cardiac amyloidosis. This is a 40-year-old patient, again, with heart failure. They saw a septal bounce on echocardiography. The pericardium looked a little thick, so they recommend getting their cardiac MRI to look for constrictive physiology. On the cine images here in the middle row in particular, you can see the flickering of the septum. The pericardium is very thick and relatively hypointense. And so that would indicate that it's too thick. Anything over 3 or 4 millimeters is going to be too thick. And then we do real-time imaging, and we ask the patients to take in a deep breath. And when they breathe in, we're looking for accentuation of the flattening of the septum or bowing of the septum toward the left. And that is indicative of increased interventricular dependence. And that's one of the most sensitive or specific signs of constricted physiology. This next case is a patient with prior aortic valve replacement, and there is a very large pseudoaneurysm around the aortic valve prosthesis due to endocarditis. It's starting to dehiss here. There's no longer adherence of the prosthesis to the aortic root. So very low, and we're increasingly using CT scans to assess for prosthetic valve complications, including in abscesses, fistulas. In this case, there's actually a fistula or perivalvular leak going around. So mid-myocardial, some people refer to it as mesocardial. So it's sort of it's not subendocardial along the endocardial surface, and it's not on the subepicardial surface either. So kind of in the middle is what I mean by mid-myocardial. Or you'll see a lot of people refer to it as mesocardial as well.
There's one more question if you have a minute.
Yeah. What was that question?
Somebody had asked if it's an acceptable general rule to remember sarcoid delayed enhancement as subepicardial versus amyloid being subendocardial.
Yeah, so sarcoidosis is frequently subepicardial in location. Amyloidosis on board exams, I think they'll say circumferential subendocardial or diffuse subendocardial. But frequently, in practice, you'll see it's just diffuse. It's everywhere.
Thanks.
This is another cardiomyopathy. We see increased trabeculation of both the left and right ventricles. This is left ventricular non-compaction. And then this is a 26-year-old competitive swimmer that presented with palpitations. The right ventricle looked enlarged. On echoes, we did a cardiac MRI to confirm right ventricular size and function. The right ventricle in this case is too large, and if we come up along the anterior wall towards the right ventricular outflow tract, you can see it's a little aneurysmal. The right ventricle in that area is pooching out, so it's dyskinetic. And so this is a patient with arrhythmogenic right ventricular cardiomyopathy. And I would recommend at some point before you take your exam, just sort of briefly review the criteria for arrhythmogenic right ventricular cardiomyopathy, because it does include MRI findings. So MRI plays a critical role in the diagnosis of arrhythmogenic right ventricular cardiomyopathy. Basically, if the right ventricle is too big and it's not working very well, then those would be major criteria in establishing the diagnosis. This is a patient with a history of atrial fibrillation and prior pulmonary vein ablation. Prior to ablation, this is what their pulmonary veins look like. And now after ablation, there is narrowing stenosis of that inferior pulmonary vein. Oops, let me go back. And one of these pulmonary veins is now missing. So it's completely occluded. And these patients frequently present with a persistent cough or persistent chest pain. You don't see it very often, thankfully, but it does occur. This is another patient with acute myocarditis. In this case, we have, you can see the bright signal intensity from the myocardial edema on the cine images. This T2 weighted image in the middle shows diffuse increased signal intensity in the lateral and inferior walls. That's myocardial edema from acute myocarditis. And then we see mid-myocardial or mesocardial and subepicardial enhancement on the late gadolinium enhancement images. And then right bundle branch block showing sort of mesocardial, mid-myocardial enhancement here in the septum. Here's kind of a zoomed in look at that mid-myocardial enhancement. And this is the patient's cardiac CT. This is cardiac sarcoidosis. So this patient did not have subepicardial enhancement. It was more mid-myocardial, but it was a little bit more focal. And the enhancement that we see on the LGE images, it's related to the cardiac granulomas. And so I think this will be the last case that I'm going to show. It's a patient with congestive heart failure. Very large left ventricle. It is not squeezing very well. And then also you'll notice that the anterior wall is very, very thin and akinetic. And then on the late gadolinium enhancement images, we have transmural enhancement. And so the fact that the anterior wall is thin and akinetic and it's enhancing, this indicates that this is a chronic myocardial infarction. Now, the way we differentiate between acute myocardial infarction and chronic myocardial infarction, we have to take into consideration a couple different findings. For me, the easiest thing to do is to look at the wall thickness. If the wall is thin, it's chronic. In an acute myocardial infarction, the wall thickness is preserved. And then over time, when the left ventricle starts to remodel, that's when it starts to thin out. The other thing that you can do is look at the T2 weighted images. So in patients who have an acute myocardial infarction, there will be myocardial edema, whereas in a chronic myocardial infarction, there will not be any myocardial edema. And so with that, I think I'm gonna pause here. If there are any couple questions, I'm happy. Okay, general MRI safety rules of perform. So in general, the valve replacements, valve prostheses that are used are MRI safe, and so and the amount of time you have to wait kind of varies depending on the device, and so you just have to look it up online. The other questions that frequently come up are related to imaging patients with devices, defibrillators, pacemakers, and for the MR conditional devices, you can kind of scan them at 1.5 Tesla, sort of in a low SAR mode. For the non-conditional devices, more and more places are starting to scan those patients, but it's sort of off-label use of MR in those situations. And yes, there's a request to fill out the survey online. Thank you again for your feedback, and thank you all of those that participated and took questions. I will send the organizers a PDF of these cases with answers in the notes within the next week or so, and they can distribute it to those of you that participated for your reference. And
If anyone didn't see, there was a link for the survey I posted. It's kind of getting buried in the comments, but I can post
yeah,
it.
and survey I can stay on